this part, there is a ligament that is yellow in color. We call it as ligamentum flavum. And in between the spinous process, there are spinous ligament, interspinous ligament, and supraspinous ligament posteriorly. And along with the ligaments and vertebral body, for the stability of the vertebra, we have paravertebral muscles. Muscles will support to maintain our erect position of the spine or the whole body. This is about the anatomy. And if you consider about the neural element inside the spine, there is spinal cord. The length of the spine is larger or bigger than the length of spinal cord. That's why here this whole is the length of spine, but spinal cord ends here, then up to here. Then there is some chorda equina, and the chorda equina is nerve root. There's nerve fibers that comes down. They're at the level of L1 and L2 chord ends, and then after that chorda equina comes. Okay, then in cervical spine, the length of the spinal cord and length of the vertebra almost corresponds. But in thoracic vertebra, the thoracic cord is shorter than the vertebra. That's why thoracic cord ends at the level of T10 here. And after that, up to the level of L1 and L2, all the lumbosacral cord ends. Okay, then chorda equina comes. And here, in between the chorda equina and the cord, there is one structure, and it contains little bit of the cord and little bit of the spinal, the chorda equina. This is some medullary elements are there. And if you consider the spine has been divided into three columns: anterior column, middle column, and posterior column. Anterior column consists of anterior half of the vertebral body, anterior half of the disc, and this lower vertebra, this anterior half of the body, anterior half of the disc, and anterior longitudinal ligament. These three structures are there in anterior column. In middle column, middle half of the body, posterior half of the body, and posterior half of the disc, posterior longitudinal ligament. These are in middle column. And a part of the pedicle is also in posterior column. But the posterior elements, there's a greater part of the pedicle, lamina, transverse process, spinous process, facet joint. These are all in posterior column. Ligamentum flavum is also in posterior column. Interspinous ligament, supraspinous ligament, these are also in this posterior column. Okay, let's go back. And this is the structure I forgot to tell. This is conus medullaris. Here, spinal cord ends, and conus medullaris, this is a triangular structure. And from conus medullaris down there, chorda equina comes. If you consider the fracture or the spine injury, there are three different types of injuries you can find. One is compression type A, it's a compression fracture. Another is distraction fracture, and another is multidirectional translational fracture. Compression fracture occurs in axial load. When patient fall from height, when there is axial compression, this type of compression fracture occurs. And there are different types, type 1, 2, 3. You don't need this. You have to memorize that there is a compression fracture when there is vertical load is exerted on the vertebral body. Another is distraction, when there is a little bit of compression over here and distraction at the posterior part, usually in seat belt injury, or when people fall from height, they tend to flex their body, and when they flex their body, compression will be in anterior part, but distraction will be at the posterior part. So the splits, posterior part splits, anterior part compresses. This is distraction injury. And when there is flexion and splitting of the posterior element, this is flexion distraction. And when there is a deceleration of injury, if suddenly car stops, patient tend to go back. In those conditions, there is extension distraction. Here compression occurs at the posterior element, but the distraction occurs anteriorly. These are distraction injuries. And compression injuries are more or less stable injuries. But distraction injury, you see, there is a disruption of the anterior and posterior whole column of the disrupted. Columns are disrupted. And these fractures are unstable fracture. And another type is fracture dislocation. Here, not only fracture occurs, but vertebral body dislocates from each other. That's known as fracture dislocation. And according to the stability, this is very stable, this is unstable, this is very unstable. Why we need this classification? According to the classification we treat. If it is a stable fracture, we can think of conservative treatment. But if there is unstable fracture and highly unstable fracture, we have to fix the spine if these type of fractures are there. So stable fracture or unstable fracture, two types of fractures are there. Usually stable fractures are when vertebral components will not be displaced by normal movement. Then it is that is known as stable fracture. But when there is significant risk of displacement of the spine followed by chances of neural injuries, if fracture is of that type, we call it as unstable fracture. So unstable fracture should be treated surgically. We have to fix the spine. Stable fractures can be treated conservatively. We don't need to, patient will not be needing any surgeries. And mostly the formula is, we have divided the spinal cord into three columns, anterior, medial and posterior column. Any two column fracture, be it anterior and middle or middle and posterior or anterior posterior, what if there is involvement of two columns, that is unstable fractures. Middle column with any another column, be it anterior or posterior, the fracture is always unstable fractures. If we see this picture here, there's a compression fracture. The upper end plate and lower end plates are fractured, little bit of compression, the posterior part is intact. Here this is also stable fracture, only one part, one plane is fractured. Here this is also superior end plate fracture, this is also stable fracture. But if the fracture goes in this anterior direction and posteriorly along with that, and there is a safe tilt of the vertebra, you can see these are unstable fractures. Here also this fracture has dislocated. You can see the body, but this has gone forward with the little fractures. If these type of fractures are there, anterior, medial, posterior column is gone. Here also two column is gone. These fractures are unstable fracture. Here this is chance fracture or distraction, flexion distraction injury. This is a chance fracture. That means through the vertebral body and the posterior element splits in a horizontal plane. And this is one of the unstable type of unstable fracture. Here anterior, medial and posterior column injured. Here also there's a flexion distraction injury. Though fracture is not there, vertebral body is intact, posterior element intact. Here disc is injured and interspinous ligament is torn. Here also there is an injury of anterior column, medial column, posterior column. This is also very unstable. If we don't treat surgically, if we don't fix this tend to move. This slips out. When patient starts standing and walking, this fracture dislocates and nerve that is going inside this canal will be compressed and patient will develop neurological deficit. This is also a picture. If we don't treat this type of fracture surgically, this happens gradually. This moves forward when patient stands and walk. And this type of fracture here also, though there is no fracture in the vertebral body, you can see this place, there's a translation at the disc place and fracture at the posterior element. There's a fracture dislocation, very unstable. Here the complete transection. Sometimes all of the spine might be translocated or if there is translation, that is very highly unstable fracture. So diagnosis, how to make a diagnosis? Always suspicion. History is very important. If there is high velocity trauma, fall from height, always we have to think of spine fracture. So examination always starts with the then suspicion. Always. That's why in primary survey A, B, C, always there is in A, cervical spine mobilization comes. Immobilize. You have to immobilize cervical spine at the first. When there is airway management, A, airway management with cervical spine immobilization that comes, because unless and until you do some investigation, you do some examination and rule out the spinal injury, patient should be immobilized properly. That is the main motto. Otherwise, by your examination, when you try to move the patient, neurological deterioration might occur, a spinal cord might get injured. And always you look for deformities, and then stepping or depressions, bruise, if there is penetrating injury or not, and look, feel, but no move. In orthopedics, there is a formula. In surgery medicine, you go there, you do palpation, percussion, auscultation, all this inspection, palpation, percussion, auscultation. But in orthopedics, there is a formula: look, feel, and move. But if there is a spine injury patient or suspicion of the spine, look, feel, but don't move. By your movement, spinal cord might get injured. And in neurological examination, it must, you know, all the neurological examination: sensory examination, motor examination. In sensory examination, touch, pain, temperature, position, vibration, these all come in a sensory examination. In motor examination, you have to know about the tone, muscle tone, how is the tone, normal or increased or decreased, and power, what is the power. Zero is no, if there is no muscle movement. 0, 1, muscle flickering. 2, there is little movement, but there is no movement with gravity. Then 3 is there is a little bit of movement in the with the gravity also. And 4, with resistance there is movement. And power 5 is this with full resistance or full force resistance, the limb moves. That is power 5. 0, 1, 2, 3, 4, 5. This is the muscle power you have to know. The reflexes. In a spinal cord injury or upper motor neuron injury, there will be exaggerated reflex. But if there is an injury of phylum terminalis or chorda equina, conus medullaris, then you will get flaccid type of, the reflexes will be absent, or there will be flaccidity. But if there is injury at the level above L1, there is an injury of the cord, and patient will develop spastic or exaggerated reflexes in the lesion below the level of the injury. And in reflexes, you have to know about the superficial and deep reflexes. Both the reflexes should be examined. And nerve injury, how many types of nerve injuries are there? There could be neuropraxia and contusion, compression, cord transection, root transection. Neuropraxia, what is it? There is no anatomical disturbance in the nerve or spinal cord. Due to the impact of the trauma, spinal cord or the nerve stops functioning for a little bit of time. After some time, it again resumes its function. That is known as neuropraxia. And usually neuropraxia lasts for about few minutes up to few hours, then gradually it recovers. Concussion means there is some trauma of the cord, but there is little bit of swelling, but there is no hemorrhage. Spinal cord or the nerve is intact. There is concussion. There is little bit of edema there. But contusion, not only the edema is there, some bleeding is there, some hematoma formation or bleeding bruise is there at the nerve. And another injury is compression. In compression, any bony fragment or ligament might, or any injury, even the hematoma might compressed spinal cord or the nerve, that is the compression injury. A cord transection is if there is a complete transection or complete cut of the cord. Usually it occurs in fracture dislocation, and that's cord transection. And sometimes cord might be intact, but the root that is coming out from the spinal cord might be transected. That is known as root transection. And you should know about the central cord syndrome, Brown-Séquard syndrome, anterior cord syndrome, posterior cord syndrome, mixed syndrome, conus medullaris syndrome, cauda equina syndrome. These are the different type of clinical manifestations that you see in the different label of the cord injury. Central cord syndrome, that is when there is a central part of the spinal cord is damaged, the peripheral part is intact, then you see about the central cord syndrome. Brown-Séquard syndrome, that is when half of the vertebra, either it's right or left of the half of the spinal cord is injured. It is known as, then the phenomenon will be Brown-Séquard syndrome. And you go to physiology, you can go and see all what is the Brown-Séquard syndrome, what is central cord syndrome. You can get it, or you can search in internet, or you can read the books. Brown-Séquard syndrome, here the motor system, half of the vertebra, half of the spinal cord is injured, so the motor deficit will be on the same side below the developed injury, but the sensory will be in opposite side. There will be mismatch of the sensory and motor, and if there is a hemisection of the vertebra. Anterior cord syndrome, that means when there is anterior, when the cord is injured anteriorly, that is known as anterior cord syndrome. And if it is there, then only the anterior part of the cord is damaged. And what lies in the anterior part of the spinal cord? This motor system. So the sensation will be intact in both the lower limbs or upper limbs, but the motor system will be absent. That's anterior cord syndrome. Posterior cord syndrome, in posterior cord there is sensory system. So if there is posterior cord syndrome, or if the spinal cord is compressed or injured posteriorly, then patient will have a normal motor or the weak motor, but motor will be present, but sensory system will be absent. And there could be some mixed syndrome, some part, a little bit of small bony fragment might compress little bit of anterior part, little bit of posterior part, and in those conditions you can get more, this mixed syndrome. And conus medullaris syndrome, you can get, I showed you, there's a little small triangular part of the spine that is below the spinal cord and above the cauda equina. There is conus medullaris. If there is injury of the conus medullaris, you will get a symptom that's a little bit of spasticity, a little bit of flaccidity, a little bit of sensory and motor deficit, but in lower limbs there's a conus medullaris syndrome. In cauda equina syndrome, usually there is bowel and bladder is involved. If it is, there's cauda equina syndrome, there's incontinence or the urinary retention will occur, or fecal or incontinence, or incontinence of the feces occurs in cauda equina syndrome. So bladder and bowel disturbance occurs in cauda equina syndrome. These are, and if you see, this is central cord syndrome. There is due to the impact, the central part of the cord is injured. This is the central cord. The periphery is intact. So this in lower limb, the nerve that is going from here and from here is intact, but the cord is injured at the center. And in central cord syndrome, the upper limbs will be affected more than the lower limbs. Usually what happens, if there is a part of the cord injury, as you go distally, there will be more injury, or the more neurological deficit is in distal part. But in central cord syndrome, distal part is little stronger or a little intact than the upper part. That means upper limbs are more involved than lower limbs. This is in central cord syndrome. Brown-Séquard syndrome, as I told you, this is hemivertebra. Half of the vertebra or the half of the spinal cord is injured. Motor in this part, since the motor part will go beyond this, so at the same side, motor will be absent, whereas the sensory side will be absent in the other limb, opposite limb. And this is anterior anterior cord syndrome. Anterior part of the vertebral body is injured and posterior part is intact. Anterior cord syndrome. And when by clinical examination, all doing, seeing the patient, looking from the back and examining, then you can suspect that patient might have this label injury at this level. And during your neurological examination also, what is the finding? You can elicit it, and after that you can decide where there might be injury, whether it could be lumbar spine, cervical spine, or thoracic spine. And you have to do respected investigations. The first investigation that is done to rule out trauma is X-ray. X-ray, anterior posterior view and lateral views and oblique views of X-rays are important. And if you suspect any injury at the level of upper cervical spine, C1, C2, open mouth view, because if you do X-ray, just only X-ray of cervical spine AP, C1 and C2 is not visualized. The mandible will obstruct it. So in those conditions, open mouth view will be the ideal one. And if you do the X-ray of dorsolumbar junction, that is means D1 and D2, and always in AP view you can see it a little bit, but in lateral view the shoulder or the arm will disturb it. And in those conditions, swimmer's view is done. When you see if you suspect any injury at about D1 and D2 or T1 and T2, you have to do X-ray in swimmer's view. Then another is if there is doubt, if there you cannot see the fracture very clearly, but if there is a strong suspicion, CT scan will tell you about the fracture in detail. And even if you see the fractures, if you are in doubt whether anterior, medial, posterior column, all three columns are injured or not, or if there is fracture dislocation, if you want to see the fracture morphology in more detail, then CT scan is recommended. And if you want to see the ligament structure, what is the status of disc, whether disc is injured or not, or if the posterior longitudinal ligaments are intact or not. If you want to see all those, then you have to do MRI. MRI will show you neural element. If there is central, it's just like if this type of injury, central cord syndrome, Brown-Sequard syndrome, if you want to see the cord in detail, then MRI will be advisable, because CT scan doesn't show this cord in detail. It will show bone in detail. That's why if you suspect about the disc injury or some injury of the nerve, if a patient has neurological deficit, always MRI is the gold standard. And they look at this. This is open mouth view. You can see this area. This is C1, and the odontite process. This is C2. But with the mouth closed, mandible will obstruct. You won't be able to see C1 and C2. But during your clinical examination or neurological examination, if you are strongly suspecting there is injury at C1, C2 level, always you have to do open mouth view. And swimmer's view, look at this, the upper cervical spine. If there is a injury of T1, T2, normal lateral view doesn't show these vertebrae. You have to do swimmer's view. That means if you see this arm is abducted, like in swimming, doing a swimming, arm is abducted. And if you want to see this area, you must do swimmer's view. And in X-ray, what you have to see is the alignment, anterior alignment, posterior alignment, then vertebral height. You see these two vertebrae are normal. This vertebra doesn't have a normal shape. Its anatomy is distorted. And here also, if you see very carefully, this is the height of the vertebral body. This is the height of the vertebral body. Here, height of the vertebral body is reduced. Here also it's reduced. There's a compression fracture. Maybe there could be a little bit flexion distraction injury, and you are not clearly seeing posterior element. There could be an element of distraction. For that, if you want to rule out all those clearly, then you have to do CT scan or MRI. And if you do, this is the CT scan, and here you can see the fracture very clearly. Fractures. These are the fracture fragments. This fragment is going back to the spinal cord, spinal column, or neural element, and this fragment might have compressed spinal cord there. That's why this retropulse fragment, that is the fragment going towards the spinal canal, and this should be treated surgically, decompress it, because this canal should have a free passage, or the spinal cord that is here shouldn't be compressed with the, otherwise there will be compression of the spinal cord and neurological deterioration, neurological deficit occurs in distal part. Here also, this is the section, this is transverse section, this is longitudinal section, transverse section. You can see this is the canal, and more than half of the canal is occupied by this fragment of the bone, and it should be decompressed. Spinal cord should be decompressed properly, otherwise patient will develop the neural deficit. And once you diagnose this, the treatment is mandatory. And what is the treatment objective? Is number one, to preserve neurological function. This is we have to preserve the nerve that is inside it, first thing, and to relieve any reversible neural compression. If there is compression, if there is partial neurological deficit, it should be decompressed completely, so that the reversible we. Then if there is partial neurological deficit, if compression continues for longer time, he will have a permanent neurological deficit. So we have to decompress as early as possible. This is the second goal. The third goal is to restore alignment. We have to make the spine alignment properly. If there is kyphotic deformity, gradually patient will develop back pain and late neurological deficit might get. That's why spinal alignment should be maintained properly, and we have to stabilize the spine. If you don't stabilize the spine in unstable fracture, initially nothing happens, but when patient stands up and starts walking, then gradually body will shift and neurological deficit might occur. And another goal is to rehabilitate the patient. Even without neurological deficit, you have to rehabilitate the patient to prevent him from getting late complications. And if there is a paraplegic patient, the patient with neurological deficit, upper limb not moving, lower limb not moving, in those conditions also you have to rehabilitate the patient. Rehabilitation is very important. So the management is, there are two type of management, or a conservative treatment, another is operative treatment. First thing is immobilization. Let's see the time. There's 3 minutes left. If I disconnect, we'll reconnect again, okay? And management, immobilization is the first thing that you have to do. ABC. In A itself, you have to immobilize cervical spine. And for dorsal and lumbar spine, unless and until you rule out the spinal cord injury, spine injury, keep patient immobilized. Don't mobilize the patient. And you have to manage the shock first. First, you save the patient, then you save the spine or limb. First, the life of the patient is very important. So in the spine injury, the patient is with high velocity of trauma, fall from height, fall from tree. There could be polytrauma, many other injuries could be there. So patients should be tackled properly to prevent from hypovolemic shock, neurogenic shock, and spinal shock. Hypovolemic shock occurs due to the loss of the blood. Neurogenic shock occurs due to the neural injuries, and there is another term that is known as spinal shock. And neurogenic shock, what is the difference? What happens in hypovolemic shock? Hypovolemic shock is due to the loss of blood or fluid. That means patient will have hypotension, his blood pressure will decrease, and by refractory action, patient will have tachycardia, isn't it? When pressure falls, heartbeat increases. When there is a loss of blood, heartbeat increases. That means hypotension with tachycardia. But in neurogenic shock, there will be bradycardia with hypotension. There will be hypotension, but there will not be tachycardia. And if you find the patient falling, his blood pressure, lowering down his blood pressure, but if and with the bradycardia, you have to understand there is a neurogenic shock. Okay, then another is spinal shock. What do you understand by spinal shock? Due to the injury of the spinal cord, there could be a contusion or concussion of the spinal cord, and whole of the spinal cord stops functioning for some time, for a little of time. Spinal cord will stop functioning. Just like current is gone, light is gone, just like that, spinal cord stops functioning. Nothing has happened there, but it doesn't work for some time. That is spinal shock. And spinal shock is always transient. Hello? Less than a minute. Let's wait for time and we will rejoin again.
Yes, sir.